Hello, everybody, and a very warm welcome to this case-in-point presentation focused on decision-making in complex PCI, how we can get by using imaging and especially by using OCT plus artificial intelligence. Here you can see on behind me the team we are going to work with. And we are going to have different type of objectives today. The first one is touching imaging and become more skilled in interpreting and in trying to understand which images has value for decision and how to react. I'm seeing something, I'm reacting in some way. And finally, we will try to get you some flavor about the artificial intelligence might help in decision making. How we are going to do, this is my full conflict of interest. We're going to use different tools. And this is Dr. Trainer working with me on the smart screen. And the concept is that we will start based upon a case. And the way we are doing all days by using angio. Here you have one example. And you might have different things that can be used in this case. You can see the proximal lesion. You can see the diffuse disease. What we are going to do is try to bring you in a different world that is using the imaging from inside to get understanding on what we will do it and how to act. For doing this, I wanted to have Dr. Badley come into the podium and tell us a little bit about the case that we will talk about.
Thank you, Dr. Julian. Good afternoon, everyone. So I hope every one of you is full energy. I know it's the middle of the day, second day of the meeting, but I won't take actually long, and I'll go directly into my case. My name is Dr. Fawaz Bardouli. I am an interventional cardiologist from Bahrain. The case that I'm presenting today is one of the usual cases that we have in our region, 75 years old male who presented with shortness of breath and ischemic chest pain for the last 4 to 5 days. He had a past medical history of diabetes, hypertension, and dyslipidemia. He's a non-smoker. Otherwise, he was active and full mobile person. His ECG showed an ischemic changes in the anterior leads, and his echo showed an EF of 25% with a preserved LV function, LV size and chamber with high elevated filling pressures, but anterior, mainly anterior hypokinesia. The chest X-ray was congested, and his bloods were fine, as you can see them here, apart from the elevated cardiac enzymes. So in brief, this is a 75 years old diabetic, full risk factors, presenting with an ACS and mild failure. So after treating this gentleman, as usual, we took him to the cath lab because definitely we have an ACS. And I will give you 30 seconds here just to look carefully into the angiogram that is caudal and epicranial, to understand exactly what is the disease extent of this patient. Definitely we are going to concentrate that this man has multivessel disease, as you can see. He has heavy calcification. You can see the LAD heavily calcified, probably in the caudal, in the epicaudal view extending to the left main. And there is a couple of tight stenosis there. And he has also a circumflex problem. So if this is your patient, and this is actually going to be an interactive session. It's not going to be from me only. It has to be from me and for me as well. So I need to hear from you. So if this is your patient, how would you react to this patient? And I need you to grab kindly your mobiles. And if we can have the barcode, what would be the option that you guys will do if this is your patient? I'll give you 1 minute and I want you to scan this barcode and answer this, and we'll look at the questions or the answers later.
This is valid for everybody. The question will follow later when we will have a face-to-face question and answer. After having seen the case as was conducted, we wanted to have some fighting on this case, but later on. 1 second for this question.
Go
Tell
ahead,
me.
Mr. Muhammad.
The ECG. I'm interested in the ECG.
Yeah, so ECG is actually preserved R waves, LAD pattern on the ECG.
Go ahead.
Okay, so I hope everyone has answered this question. So I'm going to go ahead now and show you what I have done, or what the operator did, and we'll take it step by step and see what happens. So I pre-dilated the lesion, all right? So I pre-dilated the lesion, established a little bit of a flow in the proximal LAD here, and I run the OCT. So I want you now to concentrate on this OCT run, and this is going to be a lot of discussion here, and this is very important. So I'm gonna pause a little bit here and let you enjoy the amount of calcification and the couple of pathologies that we see here in this run. Of course, this is the optic view, so we are going from distal to proximal. And this is almost, we are at the proximal, very proximal LAD, and now we are on the left main. So what I will do is, if you allow me, I'm gonna go back into this and run it and freeze it at certain points. So from distal, you can see the amount of calcification with different types of calcification, eccentric and concentric. And at this level, I want you to look carefully between around something like between 9 or 8 till this level, above till 12. So see what you are going to see. So there is something protruding from this area, and a type of a calcium that we can see, which is a calcified nodular calcification with irregular surface. And then if I let this to be run, you can see as well that there is a deep calcification, concentric, which we just passed, and there is a clot there, space occupying in the lumen. And once we reach to the proximal segment, this is exactly where the culprit of this patient was, where you can see the tight stenosis and a little of a fracture from my small balloon that I used to establish the flow. Then if I go forward to that, I want to pause a bit on the proximal LAD, which probably will come at this level. So you can see that there is definitely calcification, but at the same time, the area at this LAD here was more than 5 millimeters square. So this is the run of the OCT, and this is a session where artificial intelligence is there. So we have to give you the flavor of artificial intelligence. So the Altrion came here, and I want you to look at the Altrion run here. Of course, the Altrion runs from proximal to distal, and you can see the co-registration there. And you can see the beauty of the Altrion, where it shows you the arc of the calcium with the depth of the calcium. So for example, if I stop it at this level, you can see the amount of calcium and the depth, or the thickness, sorry, of the calcification. I think here we will make a little bit of a pause, Dr. Giulio, if you would like to use the smart screen and give us some more details.
Thank you. You are talking about a deep calcification. This is thrombus. We are not sure that based upon the days we were living, yesterday and today, everybody's understanding exactly which is one and what to do and how to react. And this is what we are going to have. Here, number one, you have the same pictures that we selected at 3 different steps. So, Mahmoud, do you want to show something?
Yeah,
and
so
here you can see.
So here we can see the thrombus. So this is how it appears inside the vessel, kind of protruding in, has a different appearance. Here we see an arc of lipid core extending across the bottom with that loss of the far field loss through the lesion here. And then here we can see the calcium here with a nodular calcification right here. So we can be able to identify the different pathologies in this case.
And the point is how I can detect the calcium, how I can detect thrombus, which one is. We are talking about the practical things. We are checking first and say that this is something that I do not like to have inside my vessel. So this is a protrusion, it's clear. When you are going to have the lumen depicted, the lumen is this one. And here you can see that you have the white, bright light, because the light is based upon two things. The one that is coming back, that is backscattering, and the one that is not penetrated. Here you can see that the light is becoming damp, so it's becoming dark. And this thrombus means that it's not fully fresh, likewise we saw in the lab case 2 days ago, but is more organized. Then Mahmoud was telling you about this type of plaque. Why is different from this one? The other attenuation after the thrombus organized is high lipid-rich plaque. What does it mean? If you are considering the opposite, you can see that the light, this is your catheter, the light is going this way, and you can see that the yellow signal is stay in change. When you are going on the opposite, it's completely damp. And that is the way we are saying this is a lipid-rich plaque. And here you can see very well demarcated the calcification. Here, here, here. So this is the way we are normally doing for getting at the point to decide. Very important, not only what do I have in my vessel, but how big is the lumen. You need to fuse the information about the type of the plaque with the lumen. Here you have to calcify plaque is shown. This is a erupted calcified nodule, and here we have the lumen. Let's go this way. So here you have the lumen that is relatively small, and this is the calcified nodule protruding inside. Mahmoud, show the lumen at a different point, the left main transition. You have a calcium, but you have a big lumen area. Forgive it. So you need to couple the content with the lumen area. That is very important. Just to get some idea about, you was talking about calcified nodule. This is a graphic scheme. You don't have only calcified nodule. You have a spectrum of the calcification. When you have some calcification and heavy calcified vessel, you might have all the type of calcification. You might have a plate. You might have calcified nodule. They are in continuity. Sometimes you have more evidence for the calcified nodule, but it's not isolated. Mahmoud, can we go to the other ones? This is the level of accuracy that pathology is bringing to us. This is a calcified nodule. And Mahmoud, can you show what does it mean in terms of penetration toward the external part of the vessel? So normally the people say be based on imaging with lumen or EL. We are talking about the fact that EL does not exist anymore, or almost, in these images, because the calcium is not going only toward the lumen, but is going toward the external part of the vessel, and it's very, very difficult. And so this is how we are judging a calcified nodule. You saw the pathology, now you see 3 different cross-sections on this case. And you can see the protrusion of the calcium that Mahmoud is showing. You can see the irregularity of the protrusion toward the lumen. And you can see the breaking point of the nodular calcification. This is the beauty of this technology, that is giving you the information at very high level of accuracy. Fawaz.
Thank you. So what I have done, of course, I was not attending this lecture and this beautiful demonstration of calcium at that time. So what I've done is a look at my pathology. As Dr. Giulio has clearly mentioned, we have a nodular calcification or eruptive nodular calcification. I have a thick calcium and I have the fibrolypid plaque. So I decided at that level to use the technology of the IVL. So I wanted to treat the concentric area of the calcification with an IVL, as well as using an NC balloon to crack the calcium all over the area of interest. So I'm going to show you now, after I've modified the plaque, what was the run of the OCT. And again, I'll keep running this. And I need you to watch here the amount of the break that you will find, or the fracture of that calcium. For example, there at 6 o'clock, here it is at around 5 o'clock. However, I need you also to notice that is the area, if you remember, that is the area of the nodular calcification that we've talked about. So the IVL, or whatever modification I've done, did not actually modify the eruptive nodular calcification very much. However, in the proximal segment, we have a good break in the calcium with both technologies, the IVL and the NC balloon. And once we reach to the proximal segment, this is where the plaque, rupture plaque was there, and the tight stenosis, we created a bit better space comparing to the old one. And still we go to the proximal LAD. The proximal LAD, there was a little bit of a small dissection, but the area, as we agreed upon initially, was acceptable. And again, we cannot give you this without the flavor of the artificial intelligence. So we've done the IVL here. And the beauty of the artificial intelligence is that everything will be calculated for you. You just need to bear in mind and see what you're looking for. So the artificial intelligence, again, the Altrion goes proximal to the distal, opposite to what we used to do. And it gives you the proximal where exactly you can land. So I decided at that moment that I wanted to land at the proximal ostial LAD, avoiding crossover to the left main, given the area is acceptable at that level. And I want to end up here. So they calculated for me the length of the treating part of my lesion. And at this point,
for everybody, you have this running AI pullback. So you say that from proximal to distal, the yellow signal is giving you where the calcium is located. Yeah. And in the previous slide, you showed that you was working with a co-registration. That is important, because here you can see when it's moving the video, you can see the marker that is coming back inside the LAD. So if you stop the video now, when there is the nodular the calcified nodule, you can see projected, displaying your angio, where is exactly this content. You don't need to have people stay away from the table and telling you more or less what you have inside. You are controlling as a single operator from the table, and you know exactly the content, and you know exactly where is this type of lesion or incomplete results.
So Dr. Giulio, do you want to show us a little bit of frames of how we modify the plaque and whether we have modified it enough or not, please?
One. This is the one, right?
Then, okay. Okay, go back one. Okay. This is quite important concept. Let's go here. Okay, this is quite important to remember how much the calcium is going not only toward the lumen, but to outside. Yesterday, there was a 20 minutes of discussion about a very nasty distal vessel, and the vessel, based upon the only section with EL, was very big. So in this case, you have almost all, but you started to have the lumen, and you needed to know that EL, in the vast majority of the AV calcified vessel, is gone, because the calcium is not going into one direction, but is going also, as you have seen from pathology, in the opposite direction. So here you can see the calcium. Give me some idea. We can perhaps recognize a little bit of a segment of the EL at this point, but the AI cannot work to detect the EL, because that is an additional feature in this case, because the calcium is destroying the EL, and you cannot get this. So you are going to be based upon the lumen. So let's go to the next one. And that is the essence. Very important. All the procedure has this magic moment. Which is the magic moment? The magic moment is lesion preparation. You decide, but then you needed to check, are we ready to get the stent implant or not? And he was showing something very, very intriguing. This is the distal part of the vessel, Mahmoud, and show the crack that is a deep crack. And you might have incision, superficial. You might have huge dissection. Here you have a crack. This is the nodule that stay unchanged because it's tough to deal with the nodule sometimes. And it was using IVL. But in this case, the only effect was to create a dissection at the border, where you have a stronger calcification and you have less calcium, because that is a weak point. And when you inflate the balloon, you can create these small cracks. But the calcium nodule was not gone. The calcium nodule remained almost unchanged and protruding. And this is the effect of this balloon dilation at the level of the soft plaque. Can you show? Here is, and on this side, you have this damp signal. You can see that the light cannot penetrate. It's becoming dark, and so it means lipid. And in this case, it was inflated balloon, but this fibrofatty lesion went back with what we call a recoil. And we are going to see later on the impact of these results. Before getting to the stent, you needed to realize if your lesion preparation was effective or not, and in which segment was effective or not.
And I think, Dr. Giulio, this is predicting what results we're going to see with the stent.
Correct.
You already know, without looking at the post-stent angio.
That is a very important point. So spend your time on lesion preparation to understand before, going segment by segment, try to get the right measurements, and try to check, because the cost of the catheter is the same if you're using before, during, or after. So it's much more important to get all the information across.
Good, thank you. So after this, I decided actually to stent this lesion with 3038 stent sky point Zions and up to the ostial of the LAD, and postulate that later on with 3.5 and 3.75 NC balloon according to the areas and the measurements we did. And this is the result that I got after the stenting. So we are running again distally that I intended initially not to treat, and then I got the distal part of the stent, so I'm going to get you back, because here we have to remember the MLD max. So we've done with the MLD, now it's the max part, so the M of any medial dissection. So this is the distal part of the stent. Stent looks to be relatively well opposed, and there is no edge dissection. Then I'm going to go proximally, and I will look at this area here now when it comes, and I will see how it behaves. So this is the stent that is in the area of the calcium nodule. And then if I let it run again, this is the mid segment, which is heavily calcified, and you will be able to see the stent with a fracture behind it, for example, here and here as well. And then I'm going to go very shortly. You can see that deep crack here. And then we will go to the proximal segment where the ACS or the lipidic plaque was there. And we cover that with a good stent. And then I'll go slowly here just to get you into that. So this is the ostial LAD. We're still in the ostial LAD, and that is the left main. So I was able to nail the ostium And that is with the help of the co-registration, because I know where I'm going to start and where I'm going to stop my stent, and that was the initial plan. And again, with the help of the artificial intelligence, we will be able actually to compare the baseline OCT, proximal to distal, and post-stenting proximal to distal. And you can see the tightest area. This is the lipid plaque here, and this is where somewhere here, the nodule, and this is post-stenting.
So one of the plus of the AI is to allow in Ultreon to compare any type of a pullback you have done. So if you have a baseline and then you are going to do some lesion preparation and you wanted to assess not only by the cross-sectional view, but also in terms of longitudinal measurements at effect, the lumen is black on the baseline. Now you have also the visualization of the stent. You can do it. You can compare the baseline with, for instance, post-lithotripsy. Or you can go at the end of all your pullbacks saying, I wanted to see how was the lesion at the beginning and what I achieve after lesion preparation plus stenting. And you have. And the two most important things that we miss during multiple life cases during this day is MLA or MSA, minimum stent area. Here you can see the minimum stent area was distally at the level of the nodule. Can you tell me how much it is?
4.9.
4.9, and proximally. That is
6.52. This is the area where we had the lipid thing.
Okay, and you have the expansion. Should be super happy about these results. Let's have a look, Mahmoud, to the next slide.
So I think you could have predicted by these findings where the fractures is, where the stent is going to expand on this case, and we see it here at the nodule area. So we expand out laterally where those fractures were occurred. Here we have a nice area here where there's calcium, but this is that fibrous area lesion here. We had that recoil, and we have this eccentric expansion of the stent without in this diameter loss. Less expansion here, and this is where we had that 6.5. This is where we had that 4.9.
Super. So what does it mean? It means that if you crack, you can get an expansion of your stent. If you are not making any significant incision of the nodule, you are going to act only on the opposite side of the vessel. And be careful, because sometimes we insist and we take a bigger balloon. When you have asymmetric calcification, this is the point you are taking some risk to rupture the vessel. Asymmetric calcification is very relevant to get some information about the imaging. The nodules was not significantly impacted by this very aggressive technology that we have today, the lithotripsy, but perhaps is not the only one in nodule preparation. And here, because you have some recoil, you can see coming back the lumen. And so if we are divided into the stent, the left side is perfectly round in shape. The right side is quite straight because he has this type of recoil. So very, very important to get these precise measurements done.
Yeah.
Back to you.
Okay. So now I have to show you how it looks like in angiogram, isn't it?
Thank you very much. Of course.
So this is the final angiogram here in the epicaudal, and this is the epicranial. After all the post-dilatation effect. And of course, this is how it ends. And I will open now the floor for the discussion and see what other people will look at it and how they will modify or do something differently. Please.
Hi, I've got a small question actually for the panel. It's a great case, beautiful case. Just for the rest of us. Can you hear us now? Yeah, good. If we find this nodule, and if you were to go back in time and do this again, and if you see a nodule like this and you decide to rotablate, can you just show us how would you measure the size of the burr that you should rotablate based on the images that you've got?
Can you go back? Okay, that is a very important information. So I detected something, how I can take the measurements. But this is valid for calcified nodule, is valid also for 360 calcification. So the fact that you are not only decide the technique, but you are sizing, for instance, the burr that you wanted to use in first. And so here, you can see that you can go to the minimum lumen area. This possibly is this one. And so you needed to take this diameter, because you have asymmetric diameter into the vessel, at least for smoothing the surface of the protruding nodule. The same is if you have a circular. Don't be in love of the beautiful imaging. Take the measurements. That is the most important message, not only to decide the rotational atherectomy, but which burr. And when you are coming back after this smoothing effect, you need to recheck, what did I achieve? And then, if you needed to escalate in with the burr, you take again the same measurements. And you are going to be oriented on the type of a burr, on the size of burr that you might have. Questions? Please, challenging us.
Excellent, excellent case. Now, the proximal need to be optimized. It's only 66. I need something like 90 probably, based on lumen data. The distal one is okay, but we lost, while working, you lost the OM. So, and seeing the OCT with angio, I would think that I will check my ACT. And the reason is that the OM, if you show us the last angio, the OM went off. So,
I have the answer for this.
Okay.
So the thing is, actually, I brought this patient because for a bystander disease. You very good observation, Sir Mohammed. So basically, the run that, because I brought the patient in a few months back later to check the LAD. So that is a checkup. So that's when I discovered that the OM, so then I opened that later on as well.
Very appropriate question, but because we are very nicely prepared, these are the images.
I need to get you a good angios, right?
And that is very important. Why? This is the thrombus that we described at the beginning. There are small thrombi at the level of the, I would say, the culprit lesion. That is something that you need to take in mind. Can you see where is the calcium? You have a calcium at a different zone. You have a here, you have a here. And you have also different thickness of the cap. The yellow one is telling you how thick is the cap on the top of the calcification. And here you can see that is thicker. Here you can see that is tiny, thinner. And not by chance, you can start to see the thrombus attached to this point, also with the plaque. And yesterday we saw a lot of thrombus located inside. So this is one of the most important points. You need to react to this situation. You cannot leave a thrombus forming. You check first the ACT. If, likewise, yesterday you still have a thrombus, you need to use B3A receptor inhibitors, small molecules, and then check after a few minutes. The patients are not the same. There is some patient that is very procoagulant, and you have one of the best tools in the world for detecting online the thrombus forming. Other questions?
Okay, considering the yesterday's talk with Dr. Fajr, the spectacle panel, and also you, and today's talk and that presentation, in the beginning you asked me, what do you do? All I do, open that very severe proximal LAD lesion, and because the calcified area that was not narrowed, because calcification per se is not that important. If it is narrow and the flow limiting, then we have to do something. So I just simply put a stent over there and forget about everything else. Otherwise, according to your talk, we have to do OCT in all of our PCIs routinely. Is that correct?
Yeah. May I answer this, please?
Yes, sir.
So that's a really valid question. But when I cath this man, I have noticed that I have the tight subocclusive lesion, and I agree with you, that's the culprit. However, I have noticed, if you go back to I can show you later on the initial, there is some haziness at that area, and I was not sure what is it. And thankfully that I have done the OCT, because it demonstrated that the area there was significantly low. And according to what I used to do is I always, if it is an area, I don't want to land my stent in an area which has a more than 50% stenosis, because I know this man will come, whether now or later, with a restenosis. Now, whether we should have used an OCT or something different, I have the habit of imaging my patients. Of course, I'm not advocating everyone has to be, but when I see that amount of calcium, I need to understand. Because if I go without knowing that there is a nodular calcification, and I crack that with a 3-5 immediately, I may end up with a perforation. Because as Dr. Julie was saying, that the balloon will be just going more towards the one side of the vessel and ignoring that. So I think in that case, at least in my opinion, I think the imaging helps me identifying what type of lesion that I have, which type of calcification I have, and I choose something that I thought that is sufficient to treat the nodular calcification. Yes?
I would add also to Fawaz, that's totally agree with this as well. But I think this is where actually we fail behind surgical results, because we don't perform enough OCTs for proximal AD. And the more proximal you are, I think you should more prone to use more OCTs, because we fail, all of us, to size the artery proximally. We always try to undersize the artery. And those people who use a lot of OCT, they reclaim, they say they have the OCT eyes, and they oversize more than the rest of us by at least 0.5 millimeter per their stents. So at least for proximal OCT, like proximal LAD and proximal vessels, I think we should respect that and use imaging for those parts of the arteries.
I don't think that the claim for systematically using in all patients, but we need to understand that the patient we have on the table today are different compared to when Sajan was teaching me what to do inside the coronary artery. And you mentioned today that you have extreme diffuse disease in younger patients, where the responsibility of the decision is becoming more important. You was debating this morning in a beautiful session, should we send this patient to the surgery or should we do something? If you are doing something, you need at least to guarantee a significant outcome to this patient. Otherwise, it's becoming a technical maneuver. Any other question?
Yes, please. Thank you so much for the case. Two questions. The first is about your point of view and the effect of IVL on eccentric calcification, specifically on OCT images. Second question is that I want your opinion on if we can then change the recommendation for the rotablation sizing scheme from a 0.66 or 0.7 to the maximum bear to artery ratio to an imaging guided sizing scheme then after all the information that we have from the OCT?
Very legitimate question. So the point is, what about lithotripsy in eccentric calcification? There are some data coming, say that they are equally effective. What we are seeing on the table, but not only with the lithotripsy, with all the devices for lesion preparation is, we really do not understand clearly and anticipate clearly the behavior of the calcification when we are treating. Sometimes you have this type of lesion and you are going with a non-compliant balloon at high pressure. I have an incredible example. So the people were guessing inside the cath lab and said, for sure it's not going to have any type of effect. Bang, open, with a multiple incision and cracks. So we are starting seeing the calcium to understand what should be done, but we don't have the data available yet. And the same is for your second question. can we be based on imaging for deciding not only the strategy, but also the tool that should be provided by the science, not by the anecdotal case.
And I would add to that, Dr. G, as well. And this is also add to the cost for the cath lab as well. I think OCT in the long run makes the procedure cheaper. You use less balloons because you definitely know the balloon that you're going to use for the procedure, this procedure, and you use this number of burrs as well because you know the size of burr that's needed for the procedure based on that OCT images.
But there is also something that is very practically important. When the imaging catheters are developed, they are not developed thinking about the type of super complex patient we are dealing. They are developed based upon imaging, the quality of imaging. And we can be today many times stuck by the fact that we have a so tortuous vessel with a huge calcification, and this is valid for IVUS, this is valid also for OCT. So there is a need to have very advanced catheter in imaging, because if you cannot navigate this vessel, you cannot see, and you lose your money. Now is the time to go back to the pole.
Yeah.
Al-Shatri.
Yes. So let's go back to the ball.
Can we have a look to the results of the poll?
So I'm happy that most of the people actually went for imaging. And so everybody almost suggests to use a small balloon and perform imaging. And that's really great.
So very promising.
Yeah, that's the right audience for the right session, I guess. But have you done the imaging? Would you have done something differently other than what the operator have done? Do you have
anyone want to understand something about the learning process? I saw something I didn't know, now I understood, and I wanted to do something different. There are many points that can be done differently in this case because we are learning.
Actually, Fawaz might have done something differently now himself. But let's hear from the audience first, maybe.
So let us hear from you. So if that was the case, and you've seen that, and you have seen how much I have modified, but still that nodular calcification is there, what would you do?
Yeah, this is exactly the point where I will modify more before I put my stent, because as you see, after deploying the stent, it's particularly under-expanded in this particular area of the nodular calcium. So I might upgrade to a larger burr size or ablation, or I use orbital atherectomy to shave more the calcific nodule and have more predictable expansion of the stent at this particular site.
Good. What do you think about, I mean, this is just an opening question, about the rota and when you have a nodular calcification? Because some people say that even the rota wouldn't work, actually, in nodular calcification. Anybody?
But the right question was addressed about the size of the burr.
Yes.
The vast majority is starting with a 1.5 without be based on sizing. And perhaps this lumen was larger, and you need to start, or you can start with a 1.5, but then you need to escalate it to 1.75. So it's very important not to be only in love of the quality of imaging, but to understand which is actionable and which action I needed to take for getting the better results. I have a clock quickly running in front of me. I wanted Fawaz to have you here. So I think that for us it was quite a significant effort. We would like to go to the conclusion. Can we have the conclusion? So the point is, what did we learn? Number one, there's a unique technology in ACS patient because it's going across all type of lesion. You have the thrombus on the upper part on the left side. It can detect the lipid-rich plaque. They are normally involved in making the ACS, but at the same time, you can also detect calcium and trace the calcium border. Below we say that a second message is very accurate for calcium detection and measure. And we had, in addition, the fact that by using this new technology, you might have automatically measure the calcium and display section by section online at the end of your pullback. And they are the last two messages. The first one is OCT cannot be used only at the beginning and at the end. But on the way, if you are spending money and effort for lesion preparation, you need to get the information when you can be ready for having an optimal stent implantation. And below you have the corresponding imaging about how was the results of the lesion preparation and how was the results of the stent. Beautiful on the left side, debatable at the level of the nodule, and also debatable at the proximal point. I wanted to recognize a big effort done by all the team, including the technical team that was supporting us for this session. Thank you for being with us.